Good afternoon, everyone. My talk is going to be about the whole gamut of Lisfranc's injury. I would like to thank the organizers for giving me this opportunity. Mr. Lisfranc is a pioneer French surgeon and a gynecologist. He pioneered in the position, lithotomy position, the amputation of cervix, etc., as well as the Lisfranc joint and the Lisfranc fracture named after him. Lisfranc described an amputation involving the tarsometatarsal joint due to a severe gangrene that developed when a soldier fell off a horse with his foot still entrapped in a stirrup. The two markings, what we have shown in the tarsometatarsal joint and the transverse tarsal joint, that's the area where we are interested in here. This is a Lisfranc ligament. Yesterday, Dr. Panchwari sir was showing in his video. That's the ligament, what you see on the plantar ligament, the two bands. The one band is getting attached to the third metatarsal base. And he, sir, compared it almost to an ACL of the knee. Stability of the TMT joints, the trapezoid shape of the middle three cuneiforms, the metatarsal bases along with their associated cuneiforms, produce a stable arch referred to as the Roman arch or the transverse arch. The keystone in this is going to be the second TMT joint. The mechanism of injury is an axial loading on an equinus foot, like what I've shown here. This is about the classification of it. And the clinical features in this, main important thing is when you see there is a plantar ecchymosis, you have to be very suspicious of it. Don't take it as a midfoot sprain. See, and mostly when usually you see this gap between on the left foot, you just notice that there's a widening of the gap between the first and the second toe. This you can notice in most of the cases when there is a opening, you can see this. Usually requires a high degree of clinical suspicion, 20% are misdiagnosed and 40% no treatment in the first week. Radiographic evaluation, X-rays, usually a weight-bearing X-ray will be of help, and CT and an MRI or a bone scan. In the normal radiograph, what are the things you're going to look at? The first metatarsal articular surface should be congruent with the medial cuneiform. The lateral border of the first metatarsal line with the lateral border of medial cuneiform, and in an oblique view, the lateral border of the second should be in alignment with that of the intermediate cuneiform, and the lateral border of the third should be in alignment with the lateral cuneiform, and in the medial border of the fourth should be in alignment with the cuboid, and the overhang should be less than 3 mm of the fifth, along compared to the cuboid. Usually what we see is the flex sign, and the stress radiograph must be obtained with the patient bearing weight in case of a subtle injuries. Suspicion of ligament Lisfranc injuries must in any patient present with swelling and tenderness over the dorsum of the foot. See, this is how in our hospital, how we do a weight-bearing X-ray. We have made a special board like this. So the patient weight bears on this board, the cassette is inside this. This is how we take a lateral. Can you compare with this? That's a normal, and the right side is going to be your weight-bearing X-ray. You can see the widening of the gap between the first and the second base. Intraoperative fluoroscopy helps to assess the stability of tarsometatarsal joint and identify any subtle injuries. This is without the stress. You can see there is no opening between the first and the second base, but the congruity is gone of the first base with the cuneiform. But if you see with the stress, can you see there's an opening of the first and the second metatarsal base? Finally, after surgery. Conservative or surgical, the goal is going to be your painless, plantigrade, stable foot, and maintenance of the anatomical alignment seems to be the critical factor in achieving a satisfactory result. Closed, undisplaced, it's non-weight-bearing cast for 6 weeks and then a weight-bearing cast. Displaced means closed by open reduction and internal fixation. Surgical intervention, best results are obtained through anatomic reduction and stable fixation. The timing of surgery, once you see the wrinkles, and best managed first 2 weeks following the inciting incident. Operating usually the incisions, what I've showed here, between the lateral to the EHL tendon, what we approach commonly, and usually the neurovascular bundle can be moved a little medial, and the third can be approached. Choice of implants is going to be the K-wire on the fourth and the fifth because there's the highly mobile region. Screws are a plate on the medial 3. See, when you're putting a screw for the first metatarsal base to the medial cuneiform, this pocket hole is important because if you don't make a pocket hole, just a drill, as you tighten the screw, it may break. The first metatarsal may break. cases, I show you a variety of cases here. It's a 40 years male, sustained injury to left foot. You can see the flex there, as well as there is a first, can you see on the CT on the far end, there's a base of the first metatarsal broken, as well as a fractured, as well as a subluxation of the first TMT. This is how we use a small stab incision to reduce the second to the first base. You can see there is, as we opened it, everything was opened like this. You can see that that's the second base. This is what we did. See, now the screw, putting the screw from the second base to the medial cuneiform is the thing commonly what it's done. Because you're aiming from a smaller bone to a bigger bone, it's quite easy, but I'm used to this, so I did this, but okay. The second case is a 35 years female, injury to left foot, 1 year back, pain swelling, difficulty in weight bearing and walking. Treated conservatively elsewhere. You just see this. This is an X-ray. In this, you see the intercuneiform between the medial and the intermediate cuneiform. There's an arthritis. The tenderness was around that region. So I did a intercuneiform fusion as well as the second base I reduced. This is after the screw removal. This is for fusion of the intercuneiform. 60 years male, RTA injury to right foot. This was his X-ray. He came in a little late. Actually, he had an erosion of all the articular surface of the first TMT and everything, so we did a primary fusion of it. This 6 months post-op. Case 4, 30 years male, injury while playing sports, swelling, diffuse tenderness. So this case, why I brought it here is, see, there is a fleck, you can see this. I did it as a percutaneous. This is one of my early day cases. You can see it's reduced and everything. I didn't open the Lisfranc area. This is after screw removal, again it opened up. So the main thing why I brought it is, don't do it as a percutaneous, always open. It's like a syndesmotic joint. You have to clear the space there. There may be some ligament or some material bone may be there, which you need to remove and do it. 60 years male, RTA, fall from two-wheeler, swelling and pain like this, like the X-ray. Did this, the plate, immediate post-op, 3 months. 32 years male, RTA, run over by a load van, basically run over by a load van, what we call as a kuttiyana, a small elephant. That's what the vehicle run over, had a laceration with skin loss, with tendon injury. Sorry about, I don't have the first X-ray, but this was a temporary stabilization, what we did initially till the skin cover can be given. You can see there is a loss of the cuboid and some of the cuneiforms also were lost in this. It's totally mangled, the foot was. This was 3 months. This was 6 months. He came with a broken screw and he was unwilling to do any of, I suggested a fusion at that point, unwilling, so I just removed that screw which was a little prominent there, causing a little trouble on that skin. This was 5 years post-op. We did it just recently. He came here like this with a severe pain with a forefoot in valgus. A lot of arthritis there. So we did a medial closing wedge and the lateral we put that same graft this side and did a fusion. 6 weeks post-op, now on the follow-up now. And this is the last case, 40 years male, RTA, diffuse swelling. This is, you can see the first and the second base, there is no any separation there. But in the CT on the top right corner, can you see that there is subluxation of the third, fourth, and the fifth TMTs? We just, I didn't put a screw from the medial to the second base. Can you see just, it was, once we reduced it, everything came back and sat in good position. When to remove the implants? Usually we remove in 6 months, wires just before weight bearing. Prognosis, poor prognosis seen in associated like pure ligamentous, high energy or ipsilateral injuries. Complications is compartment syndrome and post-traumatic degenerative arthrosis. Take-home message is going to be a need a high degree of suspicion. Controversy is primary fusion versus ORIF. Primary fusion better in young athletes, less need of a second procedure. ORIF second procedure, screw removal and may need a fusion at a later date. Thank you.
Thank you.